Welcome to AETCM, the emergency medicine channel. Today let us discuss about systemic hypertension and its management. We know that many patients will come to emergency room with high BP. Sometimes the high BP may be due to a transient phenomenon like pain, trauma, anxiety, fear, all these things. Sometimes it can be a chronic hypertension. On top of that, patient is developing acute hypertensive episode. So we should know how to handle this hypertension in emergency room, so that we need some basic information about hypertension. High BP or systemic hypertension means increased BP. There are two important types of hypertension. One is primary hypertension and secondary hypertension. Primary hypertension is the commonest thing. Sometimes we call it as idiopathic. That means without any reason patient is getting hypertension, but there may be some reason like family history will be there, genetical abnormality will be there. All these things are contributing to that, but we are not able to find out what is the reason for hypertension. Secondary hypertension means mostly they are due to endocrine causes. So many endocrine organs can have dysfunction. For example, thyroid function test. If thyroid function test is abnormal, for example, patient is having hypothyroidism, that produces hypertension with bradycardia. And at the same time, hyperthyroidism can produce sometimes high BP with tachycardia. So high BP with bradycardia, hypothyroidism, high BP with tachycardia, hyperthyroidism. So there are a lot of other conditions, including something like Conn syndrome. So there are a lot of different conditions can produce hypertension. So there is a cause for the hypertension. If you control that cause, hypertension can come down with the treatment with any major intervention in the hypertensive management. Now there are different types of classifications given for hypertension. It can be JNC 8, Joint National Committee 8 classification, WHO classification, European Society of Hypertension classification. Whatever it is, there are a lot of confusion in that. I have taken one classification. Mostly they are similar to JNC classification. So blood pressure category, normal is less than 120, less than 80. There is a problem in that classification. I'll tell you why it is a problem. When you are reading this classification, this is a standard classification accepted by all over the world. But there is a problem in that normal is given as less than 120, and less than 80. So that produces some confusion. Even if the BP is less than 120, less than 80, then if it is even if the BP is 120 by 80, that is considered as an elevated BP. So don't think that 120/80 is high BP, but according to this standard classification, that comes to elevated BP. So 120 to 129, if you see this 120 to 129, and diastolic BP less than 80, that produces elevated BP. But 120/80 or 121/81, we don't strictly classify under hypertensive stages, but we should know that there is a chance of like BP increasing that person. We should ask them to change his lifestyle. If there is a wrong lifestyle, he is going like increased intake of alcohol, smoking, increased dietary salt, sedentary lifestyle. All these things can be corrected in the early phase itself. High blood pressure, then again, it is classified into stage 1 and stage 2. Stage 1 is 130, 139, 80 to 89, 140 or above, 90 or above. So that is stages of hypertension. Hypertensive crisis means high BP higher than systolic BP higher than 180 and diastolic BP higher than 120. So isolated systolic BP is one condition that especially seen in elderly individual. If the systolic BP more than 130, diastolic BP less than 80, that is very classically used in many elderly individuals. That is an isolated risk factor. It's called as isolated systolic hypertension. It's mainly it can sometimes produces vascular damages in the brain, or stroke is the chance of stroke are very high in this type of patients. Isolated diastolic hypertension, less than 130, more than 80. So all these classifications are given to you want to understand where the patient is standing. The patient is coming to your clinic, and when you are examining the BP, you can document as first BP maybe 135 by 80. Second time without treatment, if he is coming 140 and 90, means BP is increasing. So these stages are actually given for that, not to make a diagnosis on the spot itself. You need repeated BP examination. There are certain methods to examine the BP. Some patients may directly come to the clinic or ER, and if you take the BP may be very high. For that, there are some methods, like you have to calm down the patient. Patient has to lie down for some time, and all these prerequisites are there to check the BP. So that is very important, that we are not going to talk here. And there is something called as white coat hypertension. That is normally when the patient come to clinic or hospital, when they see the doctor or nurse, the BP will slightly shoot up. In that conditions, actually you can rule out hypertension by asking the patient to lie down for some time, and frequent BP checkup by a monitor. You can easily understand whether the patient is having high BP because of anxiety, and when the patient is not anxious, the BP is actually coming down. And you can even take an ECG and see whether LVH is there or not. LVH is the classical finding used in chronic hypertension. So some patients with chronic hypertension, you can see LVH in ECG. So there is a difference between left arm and right arm, that also you should understand when you are examining the patient. And most of the patients who is having high BP, postural BP has to be examined, because there are some conditions the BP can fall down on standing. So in that condition, especially in diabetes, on sitting BP will be higher and standing will be drop in systemic BP because of some autonomic dysfunction. In that type of patients, if you start a drug which can actually increase the postural drop, patient can have sudden loss of consciousness on standing. So we have to be very careful. We have to document the postural hypotension. Now, when you are taking history, there are a lot of things we have to ask to the patient. Leading questions has to be asked to the patient: duration of hypertension, previous treatment regimes, family history of hypertension, and family history of cardiovascular disease, family history of diabetes, and dietary and psychological problem of patients. Risk factors like weight, increased weight gain, cholesterol levels, smoking, physical activity, alcohol intake, all these things are important. Then sodium in the diet. Some patients take higher sodium in the diet. No, don't think that all hypertension is related to salt. There are some salt dependent hypertension, salt independent hypertension. Some patients, when they take salt, the BP increases. Some patients, how much ever salt they take, BP will never increase according to the salt intake. So that we have to consider. Then secondary hypertension is very important. A young patient coming with hypertension, sudden onset of weakness, palpitation, sweating, tremors, breathlessness, sleep disorders like sleep apnea syndrome, snoring, sleep apnea syndrome. All these things we had hypo or hypothyroidism. Some drugs patient is taking amphetamine, phenylephrine, like that. All these things we have to consider to roll out evidence for secondary hypertension. Then previous history of target organ damage like sexual dysfunction, increased urea creatinine, renal failure, the past history of TIA, visual loss, all these things, and chest pain, all these things we have to consider. And other comorbidities like diabetes, heart disease, neurological problems like stroke, anemia, connective tissue disorders, cancers, all these things we have to take. Detailed history should be taken from any patient who is having hypertension. But remember, primary hypertension normally occurs in a patient nearly after 50 years. So the primary hypertension starts with late 40 years, then it will have a peak in the 50 years. Then we can treat that patient according to his clinical scenario. But secondary hypertension can even start before 40 years. Some patients present with 20 years, 25 years, 30 years, and they have a significant postural drop. Some of the patients who is having secondary hypertension will have a significant postural drop without antihypertensive medications. You can see postural drop in hypertensive patients who is taking antihypertensives, that is known. But without antihypertensives, if they are developing postural drop, you have to be very careful. Now, clinical features, symptoms and signs are very important. Hypertension is a silent killer. So, normally they do not have any clinical finding. Some patients can have headache. That heaviness of head is seen rather than severe headache. Palpitation is seen in many patients, even secondary hypertension you can see. Easy fatigability is one of the common finding they tell. Then if you have a hypertensive patient in your clinic, suppose you want to know whether hypertension is existing for a long time, just auscultate the heart. Loud A2 with an ejection systolic murmur in the aortic area is one of the strong points which can tell you that patient is having long-term hypertension. Then you can take an ECG and see whether LVH is there or not. Optic fundus examination, that eye examination, can tell hypertensive retinopathy. This is called as Keith-Wagner's classification for hypertensive retinopathy. Pedal edema can be there in many hypertensive patients, but remember, some of the drugs like calcium channel blockers also can produce pedal edema without any kidney disease. Renal bruit on examination is a classical finding in renal artery stenosis. Radiofemoral delay in coarctation of aorta. Postural hypotension is seen in many types of secondary hypertension. Even some drugs can also produce postural hypertension. Now, complications are very important. In any patient who is having hypertension for a long time, LVH is classically seen. You can get it in ECG or echo can be done. Atherosclerotic heart diseases, aortic dissection, atrial fibrillation, stroke, hypertensive encephalopathy, and hypertensive retinopathy. All these things can be seen. But remember, proteinuria is one of the important lab investigation which will tell you that kidneys are involved. So, before developing the actual kidney disease like elevation of creatinine, you can see proteinuria in many patients who is having hypertensive or diabetic nephropathy. Now, there are a lot of investigations you have to do in patients who is having hypertension. I am not telling all the investigation, but basically you do some investigation like one target organ problem like creatinine, sodium, potassium, calcium, thyroid function test, then uric acid levels, ECG. Why ECG is very important, I'll tell you. Because a patient who is having long-term uncontrolled hypertension, he will develop left ventricular hypertrophy. You can either get it by get that diagnosed by an ECG that shows LVH, or you can go for echo. So that has to be done. For secondary hypertension, you need lot of other investigation. Like for example, you need to do an ultrasound abdomen to see whether what is a renal parenchymal echo texture in the ultrasound. Renal Doppler can be done to know the renal artery stenosis. Like that, some investigations you have to do. I'm not telling all investigation here, but basically just do some very simple investigations like creatinine has to be done, potassium has to be done, and one ECG is required. Sugar should be ruled out. Diabetes should be ruled out. This for investigation at least you do in hypertensive patient. Now, whenever you diagnose a patient, repeated readings are required. Don't think that one reading alone we can make a diagnosis. Depending on the repeated reading, you have some recommended treatment protocol. No need to start antihypertensive immediately after diagnosing hypertension. You need some time to be given to the patient for lifestyle modification. That is very important. So, according to the BP, you can advise the lifestyle modification, review the patient. Then, if the patient does not improve, you can straight away start the medication. But higher BP or with complications of any BP, you have to start the treatment. That is very important. Now, what are the lifestyle modifications? That is very important. You can ask the patient to reduce the weight, DASH diet, that is dietary approach to stop hypertension. So that you can follow. Dietary salt should be reduced. Here also you should remember there are two types of hypertension: salt dependent hypertension, salt independent hypertension. Some of the patients will respond to your salt control. So that has to be done. Exercise is the most important thing in all types of lifestyle diseases, including hypertension. Ask the patient to go for a brisk walking at least 30 minutes per day and most of the days in a week. That is very important. Alcohol should be limited. If patient takes alcohol, then BP can increase. That's why we recommend not to come to the hospital for BP measurement after taking alcohol. That can transiently increase the BP and long-term effects on the heart and blood vessels also there. Smoking can increase the BP, so that also should be controlled or stopped. Now, depending on the BP, you have different types of antihypertensives that we'll discuss afterwards. There was a method to start antihypertensive previously, ABCD approach, either ACE or ARB, beta blocker, calcium channel blocker, or diuretic. That is ABCD approach. Now B is removed. That means beta blockers are no more first line therapy options in hypertensive management unless until there is a compelling indication for beta blocker. Compelling indication is actually it is the coronary artery disease. If the patient is having coronary artery disease, beta blocker is the best antihypertensive comparing to all other treatment. Otherwise, A, C, D approach now we can follow. There is no more A, B, C, D approach. This chart will tell you how to select your antihypertensive. So there are different categories of hypertensive medicines: thiazides, beta blockers, alpha blockers, AC inhibitors, ARBs, calcium channel blockers, and rate limiting calcium channel blockers. In that you can see the fourth and fifth. Fourth and fifth is ACE or ARB. Most of the conditions ACE, ARB, and calcium channel blockers you can start. Remember, calcium channel ACE or ARBs are not good choice in pregnancy. So that there we should avoid this. Rest all conditions ACE or ARB can be started as a first line therapy. B is beta blocker, that we don't use it for first line therapy. We mainly use the patients who is having angina, myocardial infarction, heart failure, tachycardia, all these things. Thiazides or diuretics can be used in most of the hypertensive patients. Now, diuretics, there are different types of diuretics. We use hydrochlorothiazide is the most commonly used drug, and we can also use indapamide. Furosemide is used when there is a pulmonary edema or bidal edema. Long term, even you can use spironolactone. It is a potassium sparing diuretics. There are some adverse effects which is noted here. You can see that. Beta blockers are very good antihypertensive that can control the heart rate also. Some beta blockers are used in prophylaxis of various conditions like migraine. So that also can be seen in this chart. The problem with beta blocker, now it is removed from the first line therapy because of some few side effects, or they are not desirable for the young patients. But the compelling indication for beta blocker is hypertension with tachycardia or hypertension with coronary artery disease. There it is very useful. Otherwise, this is not indicated nowadays for as a first line therapy for hypertension. But even if you start, there is no issue. There is no major side effects for beta blockers. Just they are removed from the standard guidelines as a first line therapy. That's all. AC inhibitors, ARB, it can be used in most of the conditions except conditions like renal failure or pregnancy. Some AC inhibitors can produce dry cough. That's a common side effect. Instead of that, you can go for ARB. Now, angiotensin receptor blockers have got similar action. The dry cough side effect is very less with this ARB. The similar indication, contraindication apply for ARB also. Calcium channel blockers, there are two types of calcium channel blockers, like rate increasing calcium channel blocker like nifedipine, amlodipine, S-amlodipine, and rate decreasing calcium channel blocker like diltiazem, verapamil. So diltiazem can be used in conditions where there is hypertension with tachycardia, and amlodipine can be used with hypertension with normal heart rate. If the patient is having tachycardia, most of the doctors combine amlodipine with atenolol or calcium channel blocker with beta blocker. Beta blocker controls the heart rate, amlodipine controls the blood pressure, beta blocker also controls the blood pressure. So one of the common combination which doctors use is amlodipine with atenolol. So that has got dual action. Amlodipine controls the BP, beta blocker controls the BP. Amlodipine try to increase the heart rate. That side effect will be controlled by beta blocker that reduces the heart rate. No, alpha blockers, normally it is not a first line therapy. Prazosin, doxazosin, phenylbenzamine, all these things are second line therapies. So that can be started in high BP. Centrally acting drugs are mainly used in very high BP, especially conditions like renal failure, renal artery stenosis, all these things. BP will not be controlled with routine drugs that can be used as a third line drug in most of the antihypertensive therapy guideline. Hydralazine is a very useful drug in emergency room. Previously, IV hydralazine was available in our country. Now it is not available, but even then you can give oral tablets. So it gives very good vasodilatory effect and it controls the BP. Sodium nitroprusside also can be used in emergency room to control the BP. The Serpin is available. Nowadays, the usage is very much reduced. There is a chart which tells you that where all they are indicated, contraindicated, and relatively contraindicated, not safe. All these things are given in this chart. You can read about that. I am not going to the detailed discussion of this chart. Now, goals of therapy is very, very important. Remember, we are using now ACD rule, not ABCD rule. If the initial BP is not very high, less than 160, 110, sorry, 100, follow up at 4 to 6 week interval, allow the full drug effect to be established. So the problem with antihypertensive drug is you can monitor that whenever we start an antihypertensive patient, you can see it takes minimum 2 weeks to get a peak action. Never try to start another drug in between because the first line drug itself will take 2 weeks to act its peak action. So after 2 weeks you can review the BP, then add another drug. Unless until there is a major catastrophic event, you need to control the BP drastically. You can give some time to the patient, BP will come down. Every day if you examine the BP, because of the anxiety itself, BP will increase. Now, there are different goals in different methods. You can read this. So, it depends on the condition like diabetes, there is a goal, diabetic nephropathy, there is a goal, cardiac failure, there is a goal. So, depending on the associated disease, the goals may slightly change from 130 to 120, like that, it may change. So there is something called as J-curve response. Normally, in our practice, whenever we see high BP, we start the BP antihypertensive tablet and try to reduce the BP as fast as possible. Actually, that is not required, or sometimes it can produce adverse effects. This is called as J-curve response. The problem is all our organs. Suppose the BP is very high for 1 or 2 years, maybe 160 by 110 for many years, and when the patient come to your clinic or your hospital, you suddenly try to reduce the BP 120, 80. What happens is all your organs, all the patient's organs like brain, kidney, all the organs are set for that high BP. They are well perfused only on that high BP. Suddenly, if you reduce the BP, the cardiac mortality or renal mortality will increase. The damage to the kidney or damage to the brain will suddenly increase because of hyperperfusion. So we have to be very careful. We should reduce the BP very slowly. There is no urgency in that condition. Only urgent condition in hypertension is hypertensive bleed or hypertensive encephalopathy or seizures in hypertension. Otherwise, you can wait. So depending on the disease, there are different targets. You can see this chart. For example, diabetes mellitus alone, it is 130, less than 130, 80. Almost all conditions, it is the BP is 130, 80 only. So depending on the guideline, there is on the right side you can see a chart. Depending on the guideline, there is slight change. JNC 7 gives one value and WHO gives slightly different value. But On an average, almost all comes in between 130, 140, 80 to 90. So that will be a good target. So we have discussed how to control the BP as an initial, from the initial reading. I have not told detailed management of hypertension, but initially when you get a patient with high BP, how to manage, how to go ahead. Remember ACD rule. Don't think that ABCD rule is still persisting. ACD rule is enough. ACD is AC inhibitor or ARB. C is calcium channel blocker. D is diuretic. You select one of the drug and start the treatment. We have discussed all the adverse effects, all the contraindications for each category of drugs, so that you, without disturbing that category, you can select your antihypertensive and start. Suppose the BP is not getting controlled, then you can add B, that is a beta blocker. Or if there is a coronary artery disease first itself, you can start beta blocker. Or any other drug, second line drug or third line drug, you can start. Thank you.